Presenting the case of Mr. XYZ, a 65-year-old male who is a laborer by occupation and educated up to class 10, who reside in Puri, Odisha, belongs to a lower middle class socioeconomic status according to modified Kupuswamy scale, was admitted on 6th of October and examined on 8th of October, presented with chief complaints of pain in abdomen since last 5 months, vomiting since last 3 weeks, and passage of black stool since last 10 days. History of presenting illness. The patient was apparently all right 5 months back. To begin with, he developed abdominal pain since 6 months in the upper half of the abdomen, which was insidious in onset. The pain was colicky in nature with a pain-free period. There was no radiation of pain. Pain was aggravated on taking food ingestion and relieved by antacids. It didn't affect his daily activities, and there was no episode of nausea or vomiting or heartburn sensations then. Over the last few months, he had multiple attacks of such pain. Now, since past 1 month, it has gradually increased in severity, and now it is of dull aching type and continuously present. Patient also complains of vomiting since 3 weeks, which was sudden in onset, occurs immediately after meals within few minutes, non-projectile in nature, non-bilious, initially not blood-stained, and since last 1 week, patient has noticed blood stained in vomitus. The vomitus also contained water and food particles. Patient also gave history of passing black tarry stool since last 10 days that sticks to the toilet seat. There is reduced frequency of bowel movements once in 4 to 5 days. There is no consumption of any iron supplements. There is history of loss of appetite and early satiety since 1 month. History of weight loss is present. Patient was weighing 54 kgs 1 month ago, and now he weighs 46 kg. He has lost 8 kgs of weight in a duration of 1 month. History of generalized weakness and easy fatigability present since last 1 month, which has reduced his daily activities. There is no history of yellowish discoloration of urine, eyes, and skin. There is no history of breathlessness or hemoptysis. There is no history of back pain. Past history. There is no history of any previous hospitalization or blood transfusion. Patient is not a known case of diabetes mellitus, hypertension, epilepsy, asthma, or ischemic heart disease. There is no history of recent COVID-19 infection. There is no history of tuberculosis. Family history. There is no history of any malignancy in the family. There is no history of diabetes mellitus, hypertension, or tuberculosis in his family member. Personal history. Patient consumes a mixed diet. There is loss of appetite and loss of weight is present. Bowel frequency is reduced to once in every 3 to 4 days with history of passing black tarry stools. Bladder habits are regular and normal. Patient has history of consumption of 100 to 200 ml of whiskey per day since last 35 years, and he smokes 20 BDs per day since last 35 years. There is no history of any addiction habits, any other addiction habits. Summary: a 65-year-old gentleman who is a chronic alcoholic and a chronic smoker presented with abdominal pain since last 5 months, vomiting since last 1 month, and melena since last 10 days. There is also history of weight loss and fatigue since 1 month.
Yeah. Ritwik, I think we should stop here in the history part and we should discuss this.
Yes,
so coming to your first slide, just come to your first slide.
Yes, ma'am.
Okay. So you have written about the address of the patient. So
yes, ma'am.
What type of disease is more common in this eastern belt? What type of malignancy is more common in this eastern gangetic belt?
Ma'am, in eastern side, gallbladder diseases are more common.
Okay.
And in northern and southern part, peptic ulcer diseases are more common because of consumption of spicy food.
Okay. Okay. And what else? What is Odisha very commonly known for being the number of malignancy?
In Odisha, gastric cancer.
Yeah, it's a very the gastric cancer is very common in Odisha. Okay.
Yes, sir.
Next.
Common.
Yeah. Next slide.
See. What is the significance of socioeconomic status you have written there to your case?
Sir, in lower socioeconomic status, carcinoma is gastric carcinoma is more common. And people who do in higher socioeconomic status, there is stress and consumption of tea, so it leads to peptic ulcer disease more.
So what? Okay, what kind of gastric carcinoma is more common in lower socioeconomic group, or what kind of gastric carcinoma is more common in affluent people?
Yes, sir, intestinal type of gastric carcinoma is more common in lower socioeconomic.
No, I mean to say not histological, but anatomically. Any anatomical differences you know?
No, sir.
Distal carcinomas more common in lower
Lower
socioeconomic.
socioeconomic.
Distal, why it's distal carcinomas most commonly caused due to?
H. pylori.
What's the most? Yeah, H. pylori infections.
H. pylori.
And yeah, and proximal ones.
Proximal stomach in upper socioeconomic status.
Yeah, why?
Because of drinking teas and coffee in odd times and indulge in excessive smoking.
Okay. Yeah. Next.
So we will come to the theory part of gastric CA after some time, after the completion of the examination and everything, if it's pertaining to this case. Okay, so from history, you're saying the patient was previously having pain, and after that, the vomiting and black stool started.
Yes, ma'am. Pain
Okay,
since 5
and
months.
before pain, was there any other symptom?
No pain previously.
The patient was absolutely fine since last 5 months, like
Yes,
before 5 months. Okay.
Yes, ma'am.
So what can be the cause of pain in this case?
Since it is a 5 months of duration, it can be due to peptic ulcer causing pain, or any of the chronic abdominal condition, like
Have you
chronic
described this pain?
pancreatitis.
Can you come to the
Yes, ma'am.
description of your pain? Yeah.
Yes, ma'am.
Okay.
Colicky in nature.
Okay. So upper abdominal pain, what all do you think right now as per your organ of origin, since it's upper abdominal pain?
Yes, ma'am. Upper abdominal pain can be due to chronic gastric ulcer, and also it can be due
Why
to
chronic? Why chronic? It can be acute also. Just
Yes,
tell
ma'am.
me the organs of origin that you will think of when it's upper abdominal pain.
Yes, ma'am. Upper abdominal pain can in the epigastric region, the stomach is present, pancreas is present. So
Okay.
the cause
What else?
can be due to pancreas is present, spleen and adrenal gland. These structures are spleen,
just come
lower
methodically.
esophagus.
In the epigastric region, we will get mostly the foregut structure. Okay, so in the foregut structure, what we will get the stomach, we will get the duodenum, and apart from that, we will get the in the hepatobiliary system, we will get the liver, gallbladder, and the pancreas. Usually, that kind of pains are in the upper abdomen. Okay, and also some pathology in the lower esophagus. Right?
Yes, ma'am.
Okay, so you have said that the pain was colicky in nature. In what all condition in upper abdominal pain you expect a colicky type of pain, and in what type of condition you expect a dull aching type of pain?
Colicky type of pain can be due to a involvement of any tubular structure like ureteric calculus.
I'm talking about upper abdominal cases. Okay,
or,
ureter it
bowel
goes in.
obstruction colicky. Biliary colic.
Biliary colic. Okay. Since you have said that the pain was colicky, and the first of all, the description of the pain that you have given, it is not complete. Okay. So when you're describing a pain, what all should come? Number one is the site. Okay. Number two, its onset. Number three, the duration or the periodicity and the type of pain. Okay. And number four, whether there was any relationship to the food. And number five is whether it was a referred or a radiating pain. Okay.
Yes, ma'am.
Okay. So you have said that is there any conditions where you will get other than biliary colic, is there any condition in the upper abdomen where you will get a colicky kind of pain?
Intestinal colic or intestinal colic, or in lower abdomen appendicular colic.
Okay, okay, fine. So what are the types of pain that we see in abdomen?
In abdomen, there can be a dull aching pain.
Okay,
Also, there can be stabbing pain due to a peptic ulcer.
okay. What all kind of
Burning type
pain?
of
Can
pain
you please
in
describe me the pain in peptic ulcer? It's classical.
Hmm.
Can you describe?
burning type of pain. Burning type of pain is seen in peptic ulcer or esophagitis.
No.
Okay.
What is describe everything pain?
Yeah.
Like Madam told, no, whether it's a continuous pain or intermittent pain or any association with the food or everything you should describe in peptic ulcer.
Yeah.
Yes, sir. Sir, in gastric ulcer, after the ingestion of food, there is pain. But in duodenal ulcer, the pain relieves with food intake mainly.
Yeah, so this is important as the periodicity of the pain. So you have missed that point in history. How can we understand that? What is the organ? Because see, the point of history is coming to a probable organ of origin, the probable etiology, so that it is easy for us to understand in the examination part and what to investigate later. Okay. So from your history, it is insidious in onset, it is colicky in nature with a pain-free period. So I am right now thinking of maybe something to do with the biliary colic or something. Okay. And there was no radiation of pain. That is a sort of, it can be a feature of a gallbladder type of pain. Okay. So next, what else? What else type of pain? What all the type of pain?
And hunger pain is seen in duodenal ulcer.
No, types of pain. Types of pain. There is dull aching type of pain. This can be divided according to the type of pain, like dull aching, colicky. It can be associated with, like you're saying. Tell me, what are the types of pain?
Burning type
Pancreatitis,
of
what type
pain.
of pain you'll get? I'm giving you the clue.
Yes, sir.
In pancreatitis, epigastric region, what type of pain you'll get?
Constricting type of pain.
There is nothing like constricting type of
stabbing
pain.
type pain.
Yes.
Okay. So you have to, when you ask such.
That's what Madam is asking you.
Yes, sir.
So when asked about what the types of pain, you can say one is by the duration. It can be acute pain or chronic pain. Next, it can be associated with the periodicity. Next, the type of pain, which can be dull aching or colicky or stabbing or burning, and all like this. All types should come when you're describing a pain. Okay.
Yes, ma'am. Yes.
Okay. So next is what is referred pain? What is radiating pain?
Referred pain means when the pain is felt at a distance from its source and there is no pain at the site of the disease. It is referred pain.
No.
In
No.
radiation of pain, there is extension of pain to another site where the original pain persists at the pain persists at the original site.
See, there will be a pain at a fixed site in both the cases, okay? But referred pain, you will also feel the pain at a site distant than it, and in case of radiation, that pain will radiate it to another site. I think Kishan should, these are very basic things, huh? You shouldn't have any confusion on that. It's not like in referred pain, you won't get pain at the primary site, because in the primary site is from where the pain has started, okay?
Yes, ma'am.
Okay. Next is it is aggravated by food ingestion and relieved by antacid. Okay.
Yes, ma'am.
So the patient is getting relief by antacid, but you are saying there is no symptoms of any heartburn. So when do you take antacid? What is antacid for?
Antacid is mainly for gastric ulcer.
Okay. So what are the classical features of a ulcer disease? A gastric ulcer, duodenal ulcer.
Yes, ma'am. Ma'am, in gastric ulcer, There will be pain immediately after taking food, and the pain will be relieved by vomiting. So patient will have to induce vomiting in gastric ulcer, and gastric ulcer is seen mainly above 40 years, and
So
duodenal ulcer is seen.
do you think that what is the procedure of formation of a gastric ulcer? Does it like your stomach is all right, fine, and one fine morning you get some ulcer? Ulcer is what? What is an ulcer?
Ulcer is a breach in the continuity.
Yeah,
Breach
ulcer
in
is
the
a breach in
of the
continuity.
epithelium.
So yeah, so you need a long-standing cause for that, right?
Yes, ma'am.
There has to be a cause after which an ulcer develops, right? So you have to have a conglomeration of some symptoms which will ultimately give way to formation of the ulcer. A patient first, I'm talking about the physiology or the progression of a disease. In the pathophysiology, there is never formation of the ulcer in the beginning. There has to be some derangement of the hormones, of the enzyme, or anything that will lead to the formation of the ulcer. Okay, so usually what is the course of a gastric ulcer or a duodenal ulcer? The patient has features of dyspepsia, flatulence, fullness after meals, which are corroborative with the history of dyspepsia. समझ रहे हो? All these are and later because of the damage to the stomach mucosa, we get formations of the ulcer. Okay.
Yes, ma'am.
Hello.
Yes, ma'am.
Yeah, is this clear to you?
Yes, ma'am.
Okay. So your pain is colicky and you have no any symptoms of heartburn in the previous history. Like from your history, you couldn't get any history of like that. Okay.
No heartburn.
And next is the patient has multiple attacks of such pain. It has increased in severity. So now patient has a continuous jallicking kind of pain, right?
Yes, ma'am.
Okay, okay. Next.
Vomiting.
Okay. So why do you expect a patient to have vomiting which is immediately after meals? When do you get a patient having vomiting immediately after meals? And what can be the pathophysiology behind this?
In immediately after meals means there is a rapid growth and rapid obstruction. Means stomach has no time to distend, and immediately after meals means it also suggests towards a malignancy in which the layers of the stomach are invaded, and stomach is prevented from distending. So there is immediately vomiting. Whereas in other benign conditions like pyloric stenosis, there will be vomiting after 1 day of food.
Okay, but it is not like that. In the only malignancy does not mean that the patient will vomit immediately, because ultimately the pathophysiology behind the vomiting is the same. What is it? It is a gastric outlet obstruction, which will cause the vomiting, and which is similar in both if it's due to a benign disease or a malignant disease. Okay, so this concept is not right. Samajh rahe ho? Like the vomiting immediately after meals, it means malignancy, and if it's later, then it's non-malignant. It is not it. Okay.
Okay, ma'am.
So actually you have to go back to the patient and ask the history once more. Okay, so what happens in okay, we will so this is wrong, we have to discuss it in the hello.
Yes, ma'am.
Hello. Yeah, Ritwik, come to the examination part. Yeah, come to the examination part.
Ritwik, what's your conclusion at the end of history?
At the end of history, it can be due to carcinoma of stomach or main differential diagnosis. Because he's a 65-year-old male, so I would like to consider malignancy.
Okay, what other features in favor of malignancy?
He's a 65-year. Malignancy is more common in last 4 decades of life, and here there is significant weight loss also.
Okay.
Significant weight loss, and there is loss of appetite. which
Okay.
suggests more towards malignancy.
Okay.
Ritik,
And
from history only, how can you be so sure? Because when from history we are asking you what can be the possibilities, you should keep a benign disease in your mind. Okay.
Yes, ma'am. Chronic gastric ulcer.
Yeah. And gastric ulcer, it's a very difficult course for the patient. The patient will present similarly. The patient will be a smoker because it is one of the etiological cause for having gastric or abdominal ulcer. The patient will have abdominal pain. The patient can have vomiting in relation to the food. The patient will take this thing. The patient will take antacids, like you're saying, and ultimately the
Yes,
patient is unable to eat because of so much of pain because of the ulcer, and the patient will lose weight.
yes, ma'am.
Okay. So from history, we cannot be so sure, we cannot be one-minded that this is malignancy only. Okay, we have to keep in mind the benign causes also. Plus, you have said it's a colicky type of pain. So why not you're thinking that it can be a case of chronic cholecystitis? It can be also because of the gallbladder etiology.
Yes, ma'am.
Okay. So you have to keep a very broad mind when you're coming to summary from your history. Next.
On general physical examination, patient is conscious, cooperative, and well oriented to time, place, and person. He is moderately built and poorly nourished. His height is 167 centimeters. Weight is 46 kg. BMI is 16.5. Pallor is present. No icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. So left supraclavicular lymph nodes were not palpable. Vitals. Pulse is 96 beats per minute, regular in rhythm, normal character, good volume. All peripheral pulses were felt equally and bilaterally. Blood pressure is 100 by 70 millimeters of mercury, measured in left upper arm in supine position. Respiratory rate is 16 times per minute, abdominothoracic. Temperature is 98.4 degree Fahrenheit, afebrile. Systemic examination. Patient was examined in a well-lit room in the presence of an attendant. The procedure were explained in his own language. On inspection, the shape of the abdomen was scaphoid. Umbilicus is central and inverted. All corresponding quadrants move equally with respiration. No visible mass over the abdomen. No visible pulsations or peristalsis. No scars, sinuses, or dilated veins over the abdomen. All hernial orifices were normal. External genitalia appears normal. Back and spine were normal. And the abdomen is non-tender and there is no local rise in temperature. A vague mass is palpable in the epigastric region, extending into the left hypogastrium with ill-defined borders and nodular surface. It was hard in consistency, non-tender, and moves with respiration. The mass becomes less prominent on head-raising test. It is non-pulsatile. Liver and spleen were not palpable. Hernial orifices were intact. On percussion, the upper border of liver was percussed at the fifth intercostal space along the mid-clavicular line. Impaired node was present over the mass. A resonant node present over the rest of the abdomen, including the flanks. There is no fluid thrill and septic dullness. On auscultation, bowel sounds were heard. Succussion splash was present. Digital rectal examination was normal. Examination of other system, respiratory system, normal vesicular breath sounds were heard over all lung fields, no features of pleural effusion. Cardiovascular system, S1 and S2 were present and no murmurs were present. CNS examination, higher mental functions were normal, no focal neurological deficits. Skeletal system, no bony tenderness. So provisional diagnosis, my clinical diagnosis in this patient is carcinoma of stomach due to gastric outlet obstruction.
Okay. Okay, so coming to the first page, first slide of the physical examination.
Yes,
okay, so how do you get the BMI?
BMI is height, height in centimeter by weight whole square into 100.
Huh? No. How do you calculate the BMI?
Height by weight in meters. Height divided by sorry, ma'am. Weight divided by height in height whole square.
What are the units?
Weight in kg and height in centimeter.
Height in centimeter? BMI is?
Height in meter.
Yeah, BMI is height in meters and weight in?
Weight in kg.
Okay, it is kg per meter square. Okay.
Yes.
Okay, so you have said the patient is moderately built. So you should
Yes,
also write that this is pertaining to the ethnicity and sex and age, sex, and ethnicity of the patient. Okay. So you have said the patient is poorly nourished. What all parameters have you checked to see the nutritional assessment of the patient?
Yes, ma'am. Hollowing of the temples and narrowing of the arms, and there was also parotid enlargement present.
Parotid enlargement. Does this pertain to poor nourishment?
Signs of nutritional deficiency.
Parotid enlargement.
No.
Then
Parotid enlargement.
How do you assess nutrition in a patient, in a surgical patient?
Mid-arm circumference.
Yes. We will see the mid-arm circumference next.
Mid-arm circumference and hollowing of the
first that you have done in the nourishment is number 1 is the BMI. Okay. Next, we will check for the subcutaneous fat, which is usually seen in
stomach, body mass index.
No, subcutaneous fat assessment. It is seen in the arm and the forearm. That's why we take a mid-upper arm circumference, right?
Yes, ma'am.
Okay, and what else? What else you're missing? The nutrition also encompasses both macronutrients and micronutrients. What is micronutrients?
Micronutrients, calcium, iron, vitamins.
Yeah, these are all the vitamins. So what are the vitamin deficiency that we can see in our history and physical examination?
Vitamin B12 deficiency.
In the form of?
Pernicious anemia. Pallor.
No. Pallor, yes, right. Pallor will be there. That can be both due to iron deficiency and vitamin deficiency, right? What all?
Yes.
Pertaining to vitamin B12 deficiency? We will get glossitis. Vitamin A deficiency, we will get night blindness. Okay. Yes. So you have to take all this. You have to see the nutritional profile of the patient. Okay.
Yes, ma'am. So
in this physical examination, what you have missed is the performance scale of the patient. Do you think it is important?
Yes, ma'am. Karnofsky score is to assess the performance status.
Okay, what all? There are two ways of performing this, of assessing this performance status.
Yes,
one is Karnofsky, other is
ECOG.
ECOG. Okay. So, according to you, what will be the performance score of the patient, and why is it important?
I think in this case it will be 90.
So, what is 90?
90 means he is able to do his daily activities, and there is only mild signs of illness.
So there are minor signs. Do you think in this patient there are minor signs? The patient is losing weight, the patient is vomiting after every meals, and the patient is coming to with so many complaints. Do you think this is a minor sign, or this is some significant signs or symptoms?
Yes, ma'am, significant.
Yes. So the patient will be minimum.
80.
Yeah. So how do you assess? Did you ask the patient whether the patient is able to work, whether the patient is able to continue his profession?
No, not continuing, but he is doing his daily activities like going to.
Okay. So these are all important when you assess the performance scale of the patient. Okay. And you have said that there is no lymphadenopathy in this patient.
No.
Why did you check for the left supraclavicular lymph nodes?
Because left supraclavicular lymph node is a sign of advanced sign in any cancer. Left supraclavicular lymph node is checked mainly in breast cancer, stomach cancer, or
Why only left clavicular lymph node is enlarged?
yes, sir. It is Trozier sign or Virchow's node.
I know why selectively left supraclavicular lymph node. Why not right supraclavicular?
Because a lymphatic spread occurs through left supraclavicular.
You are saying that usually in stomach cancer, we will get a left supraclavicular lymph node. Why? Why is
Yes,
the
sir.
left supraclavicular node is important?
Through the thoracic duct, and it is the sentinel lymph node.
Huh?
No, sentinel. Yeah, thoracic duct. What happens? Yeah, continue.
Thoracic duct.
What happens? O'Neill, are you there? O'Neill, unmute yourself.
Thoracic duct drain. Through thoracic duct, is goes to the left side.
Okay, then what happens?
Hello.
O'Neill, can you answer?
Yes, sir. So actually, through the left, through the thoracic duct, it drains into the left supraclavicular lymph node. So whenever there is any malignancy,
left supraclavicular. It doesn't drain to left supraclavicular. What happens?
Yes.
Near supraclavicular lymph node, what happens? Thoracic duct drains to what?
the azygos.
Huh? Not azygos. To IJV. Okay, thoracic duct drains to IJV. But what happens? Because the tumor cells are so big, okay, it cannot go from the lymphatics to the capillaries. So there will be reflux. There will be reflux because of the size discrepancy. So the nearby lymph node present there is left supraclavicular lymph node. That's why there is because of the reflux, it enters the left supraclavicular lymph node. There is nothing called sentinel lymph node or nothing like that. Okay, thoracic duct doesn't directly drain to left supraclavicular. Because of this reflux, it drains to the nearby lymph node. That is, you understood my point?
Yes, sir.
Yes, sir.
Yeah. So why the abdominal malignancy? Why the abdominal malignancy spread to the left supraclavicular lymph node? What does the thoracic duct drain?
Drain into internal jugular.
No. So all the lymphatics of the abdominal organ, including the stomach, pancreas, they drain into the thoracic duct. Okay, and the thoracic duct then drains into the junction between the. Hello.
Yes, ma'am.
Yeah. Can you tell where Abhi sir had told, no, where the thoracic duct drains?
Internal jugular vein and left subclavian.
Yes.
Subclavian.
It is at this junction. Okay.
Yes, ma'am.
So what is this node called?
Virchow's node.
And what is the sign called if it's due to malignancy?
Trozier sign.
Okay, and what is the level?
What is Trozier sign?
Trozier sign, draining into left supraclavicular lymph node.
Listen, Ritwik, listen to the questions carefully. Okay, you're not listening, only just trying to answer everything. I am asking, you told what is Trozier sign. That's correct. Enlargement of left supraclavicular lymph node is called Virchow's sign or Trozier sign. Okay. I'm asking, what is Trousseous? Trousseous.
Yes, sir. It is migratory thrombophlebitis, and which is seen mainly in pancreatic cancers.
Okay. What is Irish lymph node?
Irish lymph node is left axillary lymph node involved in gastric cancer.
Okay, good.
Okay.
Priyanka, please continue.
Yeah. So coming to your examination, you have not taken the hydration status. So a patient who has been chronically vomiting for last 3 weeks, do you think the hydration status is important?
Yes, ma'am. There will be loss of in turgor.
So how do you assess the hydration status in a patient?
Skin will be loose.
What are the subjective and what are the objective method of assessment of hydration in such a patient?
Capillary filling time, assessing the capillary filling time.
Capillary filling time, is it for the hydration or it is for to see the pillar? Okay, Ritwik, so you should stick to all these very basic things, okay, rather than focusing on reaching the diagnosis or reaching the ultimate conclusion about the patient. You should be very meticulous
For
in doing the
undergraduates,
yes.
nobody is worried about the diagnosis. Okay, nobody,
Yes.
whatever you tell, nobody is bothered. Your only approach is considered. Whether your approach is, see, madam was telling, why you want to stick on to direct malignancy at the level of history? Okay, even the peptic ulcer also simulate same features. So you keep options wide open like that. Your approach will be seen,
Yes,
and the basics like this. What is the simple in the they'll catch hold in the this thing only, head to toe examination only. They'll never go into systemic also. So whatever you have written in the case sheet about that, you should know everything. They'll ask nothing other than that. Okay.
yes, sir.
Yeah. So tell me, how do you assess hydration in this patient?
No, ma'am.
Hello.
No, ma'am, I'm not aware.
Okay.
Only you
Clean
can
So
pinch
in
is
this
there.
patient,
No. Priyanka, we have another student, his friend, Ritwik's friend, Onil is there.
okay.
He can also, for the benefit of others, you can ask
Yeah,
questions
yeah.
to both. Onil?
Okay. Okay, so whatever question Ritik is not able to answer, Onil, you can answer spontaneously. You want, yeah. So you tell me, what are the subjective and objective methods of assessing hydration in this patient? And do you think it is important pertaining to this patient? Hello? Onil?
It's not there. It's okay.
I think
Continue.
no, actually he is muted. Something has happened.
Okay,
He is
I'll,
muted.
Onil. Okay. Now can you unmute? Onil?
Yes, sir.
Yeah.
Yeah, tell him.
Ma'am, we can do the skin pinch test and look for the time required for the recovery.
Okay, that is otherwise called a skin turgor. Okay,
Yes,
next. Okay,
ma'am.
next.
And then like we can see for the general appearance like the what to say?
Okay.
Like the pulses and all, like the pulses will be feeble.
Okay.
And then we can check for the thirst of the patient, like the patient will be eager to drink water.
Yeah. So without touching the patient, first we will see. So it all goes like that. Okay, first you should see the tongue and the mucosa. It will be moist. Okay, so in dehydration it will be dry. Next is we will see the skin elasticity, and third is by the objective method is assessing the urine output. Okay, so the objective method I was talking about, it is the urine output. The subjective is, like you told, seeing the mucous membrane and the skin turgor. Okay. So you have written that anemia, like pallor is present. Where all do you assess for pallor?
Pallor in the lower palpebral conjunctiva.
Okay.
And also in the arms, nail bed.
Okay. So what level of lymph node is left supraclavicular lymph node? What level does it come under?
Left.
What are the levels of cervical lymph nodes?
Supraclavicular will level 4.
Yeah, it is level 4, level 4B.
Yes.
Okay, so what are the levels of lymph nodes? Okay, just read about it. Okay, there are level 1 to 5 lymph nodes. Okay, and there is also 6, 7 in the central compartment. One is, I will just go through it fast. 1 is submental, 1B is the submandibular, 2 is the upper jugular, 3 is the middle jugular, 4 is the lower jugular, 5 is the posterior triangle, and 6 and 7 is the anterior compartment, in the central compartment, peritracheal, paratracheal group of lymph nodes. Okay.
Yes.
Okay. Now next slide, please. Okay. So the patient has pallor, and you're telling, and it's okay if you get pulse like that. But what is the very typical pulse seen in a case of severe anemia?
Irregular pulse, irregular in rhythm,
In anemia?
and hyperdynamic and hyperdynamic pulse and thready pulse.
Is it thready?
Hyperdynamic and high volume.
Yeah. What is that pulse rate called? What is that sign called?
Bounding pulse.
It's usually a water hammer kind of pulse. Okay. Next. Come to the next slide. Okay, so coming to the abdominal examination, what all quadrants of abdomen is there, and how do you divide the abdomen into quadrants?
Quadrants, there are 4 quadrants. Right
Four
upper, right lower.
quadrants.
4 quadrants.
Okay, yeah.
9 regions.
Okay, good.
Right upper, right lower, left upper, left lower. And
Okay.
There are total 9 regions.
Okay, so what are the regions?
Right hypochondriac, epigastric, left hypochondriac, right lumbar, umbilical, left lumbar, right iliac, hypogastrium, and left iliac.
Okay, so these are important for describing. You have said that the shape of the abdomen is scaphoid. How do you assess whether the abdomen is scaphoid or flat or distended?
Scaphoid means it is boat shape. It is done by placing a scale over the abdomen, and
from the xiphisternum to the scale, from the xiphisternum to the symphysis pubis.
From to the pubic symphysis, and we have to see if the skin is touching the scale or not.
Okay. So the umbilicus is central. In what condition you expect the umbilicus to be displaced?
Umbilicus is displaced upward in any pelvic swelling, and it is displaced downwards in ascites.
Okay, and inverted, it will be inverted when there is some free fluid, when there is gross ascites. Okay.
Yes.
Okay, so what are the positive findings in our case? Come to the findings of our case.
There is a mass in the epigastric region.
Mass in the epigastric region. As you know, epigastric region is a very small region. So it is practically impossible to palpate a mass which is only confined to the epigastric region. Okay.
Yes.
Okay, so there is a ill-defined mass. It is hard in consistency.
Yes, ma'am.
What does head rising test signifies?
Ma'am, on head rising test, there will be the contraction of the upper abdominal muscle. So any parietal swelling will become more prominent, and intra-abdominal swelling will become less prominent.
Okay. Okay. Next. How do you assess for fluid thrill and shifting dullness? And one thing, if you don't have to say fluid thrill and shifting dullness together, okay? So when do you get, what is the first thing to appear, shifting dullness or fluid thrill?
Shifting dullness will appear first and later fluid.
Okay, so it's very obvious. If there is no shifting dullness, there won't be any fluid thrill, right?
Yes, ma'am.
Okay, so how do you assess for shifting dullness?
Shifting dullness means we have to start our percussion from the xiphisternum up till the pubic symphysis, and we have to access the most tympanic area. Then we have to move our finger and move to one side, and look for the area of maximum tympanicity there, and then we have to turn the patient to the opposite side. Then we have to wait for around 30 seconds to 1 minute, and the area in which we have got the maximum tympanicity will now become dull if there is fluid present.
Okay. So that's how you see a shifting dullness. So while palpating a lump, if you find an intra-abdominal lump, what are the things that you should describe in a lump?
In a lump, the size of the lump and the position of the lump.
No, first is where is it located? So according to your case, it is located in the epigastrium. Does it extend to any other abdominal region or it is confined to the epigastrium? So I'm trying to understand what case you have taken. What can be this the probable etiology from the lump that you have described? One is it is in the epigastrium, and you also try to understand what all can it be. Okay. So first is the lump is in epigastrium. Is it extending to any other region?
It was extending little towards the umbilical also.
Okay, so a mass which is in the epigastrium and the umbilical region. What is the shape of the lump? What is the shape?
It was ill-defined. So,
it was ill-defined. Can you make out the approximate size?
Yes, ma'am. So, size was around 6 into 5 centimeter.
6 into 5 centimeter. What else should you see in the mass? You tell me one of the points and you tell me what all you have seen.
Yes, ma'am. In the lump, we have to see if there is any local rise in temperature and if there is any tenderness. Then we have to look about the margins. If the margins are well defined or if they are ill defined. Then we have to look for.
So in your case, you tell me what all you should see and what is your finding. What is the margin of the lump that you have palpated?
Margins were ill defined.
Ill defined margin. Okay, next.
Then we have to look for the consistency. If it is soft in consistency or firm in consistency or hard in consistency. In this case, it was hard in consistency.
It was hard.
Yes, ma'am.
Okay. Next is.
And we have to see the movement. If the swelling moves with respiration or not.
Next.
And then we have to see if it is parietal or intra-abdominal.
Okay. And whether the mass is fixed or it is mobile.
Yes, ma'am.
Right. And next is on percussion. You have said that there is impaired note over the what do you mean by impaired note? What are the types of percussion note that you get over abdomen?
Resonant node and dull node.
Yeah. So on the mass there was a dull note.
Yes, ma'am. Dull.
Okay. So what is drop space?
Drop space. It is the region of the lining on the fundus of the stomach.
It is a crescentic space which is present over the
spleen.
No, it is not present over the spleen. When it is usually resonant, when do you think it gets dull?
It is dull in splenomegaly and in ascites.
Okay. Okay, and it is also encompassed by the lower edge of the left lung. Okay.
Yes.
How do you mark it from outside? It is seen in the region of the left sixth rib and the left anterior axillary line and the costal margin. Okay. There you can see the drop space.
Yes,
hello.
Yes, ma'am.
Are you able to follow?
Yes, ma'am.
Okay. Okay. Now come to the auscultation. So you've written DRE is normal. Okay. So yes, you have said that the patient has already history of passing black colored stool. So you think that while doing a DRE, you can assess that?
Yes, ma'am. On black color stool, we can access.
Yeah. So in DRE, if there is a melena, you should mention that what is the color of the stool that you have assessed while doing a DRE. So I've written that suddenly in the auscultation, there is succussion splush.
Yes, ma'am.
But there was no swelling in the, there was no lump or anything in the epi. There is this one hard lump in the epigastric region.
Yes, ma'am.
and there is no gastric distension. As did you do auscultopercussion in this patient?
Yes, ma'am. That auscultopercussion was done.
So do you think was the stomach distended? Do you think that the greater curvature was below the umbilicus, or where was it? What was the finding of your? So if you're writing succussion splash, how do you see succussion splash, and what does it signify?
Means the stethoscope is put over the epigastric region after
Okay.
3 to 4 hours of nil orally. Means the patient has not taken any food up to 3 to 4 hours. Then
So the prerequisite is the patient should not take anything for 3 to 4 hours. Next.
Yes, ma'am. Then a closing sound will be heard due to presence of any gas or fluid in the obstructed organ.
Yeah. So why do you get a succussion splash? What causes the succussion splash?
Delayed gastric emptying.
No, not delayed gastric emptying. Succussion splash means that there is a distal obstruction and there is accumulation of air and some fluid proximal to that. Yes, which is getting accumulated, right?
Yes, ma'am.
So that's how, if it's a complete obstruction, when there is no air, will you get a succussion splash?
No.
Okay, so we get a succussion splash because of some distal obstruction, which causes accumulation of fluid and food materials and air proximal to that. And when we move the patient in that way, we get the splashing sound, which is the accumulated fluid.
Yes, ma'am.
So do you think we can get succussion splash if the stomach is not distended?
No, it has to be distended.
Yeah, so when you're writing about succussion splash, then you have to mention the auscultopercussion findings, whether the stomach was distended or not. Because after all this history, when I'm coming to auscultation, there is this one sign where I can think, okay, it can be a case of gastric outlet obstruction, because none of the finding that you have told about has pertained to the finding to the conclusion of gastric outlet obstruction, isn't it or not?
Yes, ma'am.
Okay, next.
What is Blummer shelf, Ritwik?
Metastasis to the pouch of Douglas.
Okay.
Pouch of Douglas.
Pouch of Douglas.
Pelvic metastasis to pouch of Douglas.
Pouch of Douglas, is it present in both male and female?
No, only male.
What is that? In males, what it's called?
Retrovesical pouch.
What are the signs of distant metastasis in case of carcinoma stomach?
The most common site of metastasis is to liver. So there will be jaundice and abdominal pain or abdominal distension. And also there will be cough or hemoptysis is the and Sister Mary Joseph nodule will be seen. It is due to the periumbilical metastasis and also Krukenberg tumor.
Why? What is the reason for Sister Mary Joseph nodule?
Periumbilical metastasis.
Why only periumbilical? Selectively, why periumbilical? Why not just laterally or somewhere else? Why not in epigastric region? Why it's around the umbilicus only? What is connected from the stomach to the that umbilical region? What is connected? Through what it gets spread? I'll give you a clue. Which ligament?
Yeah.
Okay. What is Krukenberg's tumor?
Krukenberg bilateral ovarian metastasis, which is due to retrograde lymphatic spread.
You have to read all those things. I can keep telling you, but that's not the way to teach. Okay.
Yeah.
You have to read. This is your case. One case you should have read everything in detail. Everything given the book. It's nothing. We are asking something hi-fi or no. All these are UG questions.
Yeah, we have not even gone to the case. We are really sticking to the basics. Okay. because the examination part only is not complete. The history is also not complete. Have you taken any history which is pertaining to any metastatic symptom?
Yes, sir. Yes, ma'am. Like bone pain or
Go systematically a little bit. Why first bone pain?
yes. First, there was no breathlessness or cough.
Okay.
So we have to rule out metastasis to lungs. Jaundice. There was no yellow discoloration of eyes or palms or any abdominal distension. So we can rule out metastasis to liver.
Mm-hmm.
And also there was no bony pain, so we can rule out metastasis to bone.
So in history, I have not written all this. Okay. So in history, you have to take a detailed history of any metastatic symptom or not. Okay.
Yes, ma'am.
Okay. So what is your case? Summarizing both the history and the examination.
Summary, sorry, diagnosis. It should be ulta. What you written? Diagnose case of carcinoma stomach due to gastric outlet obstruction or gastric outlet obstruction due to carcinoma stomach.
Gastric outlet obstruction due to carcinoma stomach.
Then how can it be carcinoma stomach due to? Huh? We don't read what we have written. Okay, how do you manage now? How do you manage this case?
Okay. Management it can be surgery, chemotherapy, and radiotherapy. Surgery is done for
No.
See, when I ask how do we manage, first thing is investigations. Have you?
We have to do the ultrasound.
You confirm that it's a CS stomach. How do you confirm?
Investigation of choice is endoscopic ultrasound.
No, my God. Ritwik, I think you should really stick to basics, okay? So we are not expecting all this endoscopic ultrasound surgery and everything from you, okay? So first of all, I think, Kishan, we should stop here and just tell them what ideally should be done. What do you think?
Okay, fine. No, he has read.
Because
He's a bit nervous. He has read.
No, I can understand totally. He has read, but the thing is that we are not searching for surgery, radiotherapy, or chemotherapy at this stage,
Yeah, okay,
So we want to reach to a diagnosis. Okay. So when asked how do you proceed in this case, first, see, we don't have a diagnosis in hand, right, Ritwik?
Yes, ma'am.
So first, you should say that I should do some investigation to reach to my diagnosis, and then I should do some investigation to stage my disease, and then I should do some investigation to final plan the management of my patient, right?
Yes, ma'am. Yes,
okay. So first of all is why do you say that there is gastric outlet obstruction?
Because of non-bilious vomiting.
Okay, so you have some points in your history, you have some points in your examination, right?
Yes,
so from history, you're saying that the patient is having vomiting after meals.
Yes, ma'am.
Is there any fullness after meals? Why do you think your patient is vomiting? What is usually the physiology of vomiting? Why do you think a patient vomits?
Because of GIT irritation.
Okay.
Or any obstruction at the distal region of the stomach.
Yeah, so there is a retrograde peristaltic waves, right, which causes the vomiting, which causes the expulsion of the contents, which is usually that's why we usually get a projectile, so-called projectile type of vomiting, because it's a retrograde peristaltic waves which causes this vomiting. So when there is a gastric outlet obstruction, what all do you expect in history that your patient does not have?
Yes, ma'am. If it is infantile hypertrophic pyloric stenosis, then the child
infantile
will have,
we are not talking about this, no, Ritwik. The patient is a 65 years gentleman, so we are not talking about infantile causes.
Yes, ma'am. Gastric outlet obstruction, projectile vomiting, and dyspepsia.
Okay. So what is a gastric outlet obstruction? Then coming to that, what do you mean by gastric outlet obstruction?
Uh,
What is the
um,
outlet of the stomach? What is the
uh,
outlet of the stomach?
yes,
Onil, can you answer? Or anyone?
Yes,
Anyone
sir.
who's
So it is
interested, please.
the
Vignesh
stomach
Malya.
pylorus.
Yeah, so it is the antropyloric region which forms the gastric outlet. Okay. So when there is a obstruction in the antropyloric region, we usually get a conglomeration of symptoms and examination finding, which is called as the gastric outlet obstruction. So what are the classical findings in a gastric outlet obstruction? We get a sensation of fullness after meals. The patient has vomiting after meals, which usually contains the old food particles. And the patient usually have vomiting towards the evening after having the breakfast and the lunch. And the patient also has sensation of a mass in the abdomen, which usually moves around. Hai ki nahi?
yes, ma'am.
Leave everything. You tell me 3 classical symptoms of carcinoma stomach. 3 classical symptoms or features. Sorry, not symptoms. 3 classical features. 3 A's.
Anemia,
Anemia,
anorexia.
anorexia, and dyspepsia.
I am telling 3 A's and you are telling dyspepsia. Onil, anorexia, anemia, and third
Anorexia
one.
will be there. Anemia will be there.
Third one, weight loss. What do we call that? In A. This is the typical to diagnose a carcinoma stomach. These 3.
Unintentional
Asthenia.
weight loss.
Asthenia.
Okay.
Okay, patient will be this thing asthenic. Okay, so asthenia, anorexia, and this thing. These are classical 3 features of carcinoma stomach. Okay, and okay, we'll Priyanka, basics. Let them study. We'll just finish off with the management, and we'll end this. Okay. So
Yeah, okay.
yeah, Onil, how do you manage this case now?
So first of all, we need to take him up for investigations.
Okay.
To confirm our diagnosis.
Hmm.
So I would like to do an endoscopic biopsy in this case to confirm the diagnosis.
Okay.
And then I need to do the staging of the disease because I need to go up for management purpose. So as per the staging of the disease, then I will like to go forward, like whether I need to give chemotherapy or radiotherapy or like new adjuvant chemotherapy
What's
or
early
go
gastric
along with the
cancer?
surgery. Yes, sir.
What is early gastric cancer?
Not sure, sir.
Oh, Ritwik or anyone?
Cancer is above the muscle layer. Type 1 gastric cancer, polypoidal type.
No. What is early gastric cancer? You are simply unnecessarily complicating the things. You are asking very simple questions, basic questions. Who will answer? Vignesh or anyone? Habib Shah? Dr. Habib Shah? She is also having exam, so let her answer. I want to unmute her 1 second. Habib Shah?
Yes, sir. Can you repeat the question, sir?
Yeah, what is early gastric cancer? Only sorry, Ritwik has already answered, but in a different way. Any cancer limited to mucosa and submucosa only. That's called early gastric. Okay.
Irrespective of the nodal status, if it is confined to the mucosa and submucosa, it is known as the early gastric cancer. Okay. So actually, for this case, your approach would be a little different from the other usual scenarios, because a patient who is having a continuous vomiting, who is in a gastric obstruction, it's a type of semi-emergency case. Okay. So in this patient, what do you think your approach should be? First is resuscitation and stabilization of the patient. Okay. Hello.
Yes, ma'am.
Yeah.
Yes,
So
ma'am.
what all metabolic derangement are you expecting in this patient? So what all blood investigations?
Classical
Like there will
description
be
of the
hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria.
Incomplete. Abib Shah?
Metabolic acidosis, sir.
No.
No. What kind of metabolic alkalosis? Yeah, tell me, Ritwik.
Hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria.
Okay.
You should read why paradoxical aciduria. Okay. Fine.
Yes.
Next.
Yeah. So
You should
first
do
is
resuscitation. This
first
electrolyte
is
imbalance should
resuscitation
be
of the
corrected.
patient. Okay. So next we will go for investigations. What all investigations you think is necessary in this patient?
Ultrasound.
Okay.
To look
One ultrasound to look for.
mass or any liver enlargement or fluid ascites.
Yeah. Okay.
And then we have to do endoscopy.
Okay. One. What kind of endoscopy?
Upper GI endoscopy.
Yeah. One upper GI endoscopy with. Can you do anything in that setting to
We can take a
confirm your
biopsy
diagnosis?
sample. Take a biopsy sample.
Biopsy sample and EUS can also be done for staging also.
No, see, US in the sense that we don't know still whether it's a gastric cancer or not. It can be a case of a gastric ulcer, duodenal ulcer. Okay.
Okay.
We can take a sample for biopsy.
Okay, one is you take sample for biopsy. What else? The patient is having dyspepsia and all this symptoms of hyperacidity. What all you can do? What is the invasive method of detecting H. pylori? Hello?
Yes, ma'am.
So we can do a rapid urease test for H. pylori in the same sitting by taking the mucosa. Okay?
Yes, ma'am.
Okay. Next is you have done a UST, you have done a upper GI endoscopy, and anything else you want to do for this patient? Suppose, okay, fine, I will give you now a scenario. On the upper GI endoscopy, you can see ulcer proliferative growth, which is in the antropyloric region, and your scope cannot be negotiated beyond. Okay. And you have done a biopsy, it has come out to be poorly differentiated adenocarcinoma with signet ring cells. Any investigations you want to do?
Chest X-ray to see metastasis.
Okay.
PET CT scan, ma'am.
Whole body PET CT scan to for TNM staging.
Why PET? Why PET for TNM staging? Can't we do a CCT? PET is a very expensive investigation, and we should only restrict it to some definite cases. Okay. So in this case, a CCT scan of the thorax, abdomen, and pelvis is sufficient to stage my disease and to see the local extent of the disease. Okay. So now you're planning a definitive surgery for this patient. What all investigation you should do, and how do you make the patient fit for surgery? Do you take this patient directly on OT table, or you think that this patient needs some kind of preparation?
First, we have to see the signs of inoperability of the tumor.
Yeah, that we have seen in the CT scan. We have ruled out any thoracic mates. We have ruled out any signs of any local inoperability in view of invasion into surrounding organs or anything. The patient is operable. You have planned the surgery for this patient. So I am asking you, how do you make this patient fit for surgery? What are the problems that this patient has which needs some correction before surgery? Because it is going to be a big surgery, no? What all issues your patient has?
Correction of anemia is needed, nutrition should be provided, and fluid electrolyte imbalance has to be corrected.
Okay, so first is, if my patient is dehydrated, right? The patient is having vomiting after every meals. So number one, you will correct the hydration status of the patient. How will you correct? What is the fluid of choice?
Normal saline.
Yeah, normal saline supplemented with? You only said, no, it is a hypochloremic, hyponatremic. Yeah, what is the daily requirement of potassium? That is 1 milliequivalent per kg. Okay, that is the potassium requirement. So first we have to correct the dehydration status. Next is? You said that the patient has pallor. Can you operate a patient if the patient has pallor and a hemoglobin of 5?
No, ma'am.
No.
Okay. So what do you need for that?
One PCV we can transfuse before.
We need to get the blood grouping done.
Okay. Blood grouping, cross matching, and blood transfusion.
Arrange for blood
Okay.
products.
Okay. Yeah. So 1 or 2 that will be decided by your hemoglobin level. Okay. So we will correct the anemia with the help of blood transfusion. Next is the patient is not eating. The patient is not eating. The patient is vomiting whatever he is taking. So what all abnormality do you expect in his LFTs?
Albumin will be low.
Okay. So what we can do for this patient if the total
141
protein and albumin is low?
nutrition.
Why? What kind of nutrition?
Parenteral nutrition.
We should give the patient a short course of total parenteral nutrition. Right?
Yes,
Okay. And also we have to prepare the patient with a gastric lavage. Okay. Because the patient already has so much of food residues, infected materials inside. So it's better if we clear out the food residues before surgery so that our field is not contaminated. Okay. Okay.
Abhipsha, tell me why we need to decontaminate or why we need to give rest before do surgery, stomach. Why we need to give stomach wash? Although it's not done regularly, but what is the principle behind using any colonic wash or stomach wash before the surgery? It's for PGs.
Sir,
What
while
happens? For example, we'll be doing a gastrojejunostomy. Okay, what happens? If there is already inflammation or edema is there, what will happen?
while anastomosing side, the healing will be very delayed, sir.
Okay, no more than that. Delayed healing. What will happen if there is edema already? When you put then the edema subside, there can be leak, right?
Anastomotic leak
Anastomotic leak can be there. So you give stomach rest by putting the trials tube or by saline lavage. Okay, you wash the contents out so that this whatever the inflammation, whatever the edema is there, that will subsided. Then if you operate, then the anastomotic leak chances are less. That was the principle earlier. No more holds. Priyanka, do you still follow that?
Actually, it's not because of that. We give a gastric wash because these patients usually have a hugely distended stomach with lot of residual food particles.
Yeah, that is
So
there.
that's why we give a gastric lavage. Yeah, so when just after opening the stomach, there will be a lot of food materials, everything coming out in your operative field.
Yeah, no, because of
So
stasis, lot of
because of the
stasis will be there.
stasis.
That will also cause this edema. Okay, because of so to bring down that, that's also another factor. Okay, what's the treatment? Now finally there is a operable tumor is there. It's present in the distal 1/3 of the about 5 centimeter tumor. Okay, Ritwik, you're listening?
Yes, sir. Yes, sir. Yes, sir.
Okay, in the distalmost part of the stomach.
Surgery for
so no
primary
signs
tumor.
of any metastasis. Okay, patient is operable, fit for surgery now. What we will do?
Yes, sir. So we have to take the proximal margin at 5 cm and distal margin at the pylorus, and there are total 3 types of surgery.
Distal margin.
How much? Distally, how much margin?
If the tumor is at the distal stomach or prepyloric region, then we have to do distal gastrectomy in which 30% of stomach is removed.
O'Neill?
Yes, sir.
Answer.
So we can go for a distal gastrectomy, sir. As you said, it's in the pyloric region.
How much margins, proximally or distally?
So I had read the same thing, like it's 5 centimeter proximally and distally till the pylorus.
Distal till the pylorus. If the pylorus is involved, then
like we need to like extend the margin even further, distal margin.
How much?
Not sure of the exact dimension, sir.
Okay, in 1 centimeter distally. Okay, 5 centimeter proximally. Okay, and after that, after the resection, what you'll do?
Do you leave it like that or you reanastomose with something?
Yes,
that's a half answer what you told.
Esophagojejunal anastomosis.
No. You're keeping the
gastroduodenal anastomosis. We can go ahead with the gastroduodenal anastomosis.
Okay. What is Billroth's surgery?
So it is done for gastric reconstruction. So there is like Billroth 1, Billroth 2.
Abhipsha, you know details?
Sir,
Like in Billroth 1, we do the
gastric
end-to-end gastroduodenal anastomosis.
Hmm.
In Billroth 2, we do end-to-site gastroduodenal anastomosis.
And what is the recommended nowadays for this stomach distal cancers? What surgery?
I think so. Billroth 2.
No.
Sir, Roux-en-Y gastrojejunostomy.
Yeah, it is a Roux-en-Y gastrojejunostomy which is recommended. Okay.
Please read what are the problems with Billroth 1, why they found Billroth 2, what are the again problem with Billroth 2, and why
What are the
doing
complication of gastric resection? There is something called dumping syndrome and everything that you have to read up. Okay.
So any other questions? One last 2 questions for Priyanka. Okay, what are the possible complications after the Roux-en-Y gastric jejunostomy?
There can be a
like
duodenal
dumping
stump
syndrome can be there.
Then?
Dumping syndrome.
Okay, then other things.
Weight loss, like nutritional complications.
Okay.
Yeah, the nutritional complications are very important. Okay.
Like most
ulcers
commonly we undergo
at
iron
the
deficiency.
anastomotic site.
Ulcer at the anastomotic site?
Yes.
Not understanding.
Or
like there can be hernias, internal hernias.
Okay. When we get what is that hernia called?
So in case of if you do anticolic
Peterson's
gastrojejunostomy, we'll get Peterson's hernia. If we go for retrocolic, we get the Stemmer's hernia.
Very good. Very good.
Yeah.
Okay. So we have to close this thing also. What is that?
Mesocolic window.
Window also.
Yes,
whatever. Okay. We have to close that. Otherwise, there is a chance of hernia. Good.
Stemmer's hernia.
So yeah, after that dietary supplements you should give for the follow up. Okay.
Yeah.
Yeah, they should
Anything
go
else?
for small, frequent meals.
Okay, if it's not non-operable, if this case is non-operable, patient is having severe gastric outlet obstruction and signs of distant metastasis are there, then what you'll do?
You can go for chemotherapy, sir.
Okay.
Patient is vomiting in front of you.
No, yeah,
The patient is having this anatomical problems. So what all can you
chemotherapy
do
will
for
not
this patient?
solve the solution.
Achha, what do you mean by palliation? What is a palliative chemotherapy? What is a neoadjuvant chemotherapy? Is there a difference between these two?
Yes. Neoadjuvant chemotherapy is given before the surgery to downstage the
to
tumor
downstage
size.
the disease.
Neoadjuvant when you're planning a surgery, and what is palliative?
Just for the symptomatic management.
Okay, in this case also we can do palliative surgery just to bring down the tumor burden and to relieve that gastric outlet obstruction. Okay, to relieve the obstruction we can do either go for palliative surgery, or else we can what else can be done for feeding, just for feeding purpose? What else other surgery can be done, O'Neill?
Feeding jejunostomy.
Yeah, feeding jejunostomy can be done. Okay, if the patient is not fit for extensive surgeries and all, then you can just go for feeding jejunostomy. Okay, and read about the role of chemotherapy and radiotherapy, neoadjuvant, everything in this case. Stomach cancer, very important. It will invariably asked either in the theory or in the practically. On case will be there anyway. This thing. Okay, but what's your concluding remarks, Dr. Priyanka?
Yeah, so one remark I really want to make for the MBBS students who are listening to us, one thing is that please focus on the basics, okay? We are not expecting the surgery, malignancy, chemotherapy, radiotherapy. We are not expecting all this from you, okay? But you should be very thorough with your basics. Like you should be very thorough with about how to take the history. What is the progression of the disease? What are the types of pain? You from your history taking, you should be able to correlate that what organ am I going to. And next thing is you shouldn't be biased. Okay, there is no role of being biased. If you are biased, it is malignancy only, I have to prove this, then you are going nowhere. Okay, so you can't be biased while taking your case. You have to have an open mind. And next is, you should focus on the basics. We don't expect any hi-fi things from you. Just focus on the basics, focus on the clinical part, see patients, talk to patients. That's how you can take a good history and examination. That's all.